One, please start, sir. We are live.
All right, so friends, welcome to this webinar today. This is the 12th webinar of the Gujarat Pediatrician WhatsApp group. And since last few, we have joined hand with the Surendranagar District Pediatric Doctors Association. And Zydus has been kind enough to provide us the unrestricted scientific grant since the beginning. Of course, as Dr. Ramesh was reminding me that we had first seminar, on common surgical problem with Dr. Amar Shah. That was almost 10, 11 years back. And we are back now on a webinar platform with a similar topic. So myself and Dr. Ramesh Bajania will moderate as usual, and we have extremely eminent panelists today. We have Dr. Amar Shah from Ahmedabad, Dr. Ravindra Ramadwar from Mumbai, and Dr. Roberts from Bengaluru. And before I introduce them, our gratitude to Zydus for providing unrestricted scientific grant for all our webinars, including today's webinar. So I would like the medical director, Dr. Triambak Datta, who is here, to say a few words before we start the webinar. Triambak, unmute.
Thank you so much, sir. And thank you everyone for this opportunity. This is Dr. Triambak from Zydus Vaccines, and I shall be quickly taking you through the presentation. So, as you all are already aware of, Zydus is a very well integrated pharma player with proven track record and with over 23,000 people getting impacted across 4 continents and 300 plus generic products, 20 active discovery programs which are on with more than 1,400 research scientists working day in and out across 5 niche therapeutic areas, including biosimilars, transdermals, vaccines, pulmonary, and oncology products. So Zydus has been launching products that address the unmet needs. Some of the novel biologics and vaccines are Lipaglyn, India's first NCE to treat diabetic dyslipidemia, Exemptia, world's first biosimilar of adalimumab, Vaxiflu 4, India's first quadrivalent influenza inactivated vaccine, Twinrav, novel, first of its kind, cocktail of 2 monoclonal antibodies in rabies post-exposure prophylaxis. Bilipsa, first drug to treat first drug to get the regulatory approval for NAFLD and NASH. ZyCoV-D, world's first plasmid DNA vaccine, and Oxemia, which is a breakthrough treatment in chronic kidney disease. So just a quick snapshot for the Zydus vaccines. We acquired Etna Biotech, which is the state-of-the-art R&D in Italy, and we have in India we have the inactivated vaccine facility, the live viral facility, the bacterial vaccine facility for Zydus TCV and recombinant and other vaccine facilities. So the journey started in 1990 with starting the foreign vaccine and Vaxirav N being launched in 2000, 2008. We acquired the Itna Biotech, Vaxiflu S, India's first Zydus was the India's first company to launch the monovalent influenza vaccine. Vaxiflu 4 was launched in 2015, which was India's first quadrivalent influenza vaccine, followed by a division of vaccines, that is VaxiCare, and the Zyvac TCV, that is the typhoid conjugate vaccine, followed by Twinrab and Zyvac MMR, and so on. So these are our awareness initiatives, the We Care initiative to improve immunization rate in the country, the Fluxination initiative, the Typhoid Doesn't Discriminate initiative, and the Viram initiative for putting a full stop on rabies. Before I end, just wanted to update all of you that the Zydus inactivated influenza vaccine is now upgraded with a 25 gauge Terumo needle, a universal solution for catering to all age groups. And with that note, thank you so much, and over to you, sir. Thank you.
Thank you, Triambak. If you can stop sharing. Yeah. Okay, let me go back to my PPT. So thank you, Triambak. Let me introduce the today's panelists. before we go to the chief guest of today's webinar, we have Dr. Robert. He's the director of Kinder Surge. He's a pediatric surgeon and a pediatric neurosurgeon at the Bangalore. We have a very good friend of mine, Dr. Ravindra Ramadwar, who is a consultant pediatric surgeon and an excellent, I would say, among the first few laparoscopic surgeon in the country. He works at Hinduja hospitals and various other hospitals, and that's how I know him very well, because we day in and day out see patients from one another. And last but not the least, our own Gujarat excellent pediatric surgeon, Dr. Amar Shah. I mean, he has the legacy of his father, also being an extremely amongst the first few pediatric surgeon of the country. So Amar is consultant pediatric surgeon and a pediatric urologist, and he's the director of the Amardeep MultiSpeciality Children's Hospital at Ahmedabad. So with that, I would now request Dr. Bajania to take over and.
Yes, Nitin Bhai. So, respected Dr. Nitin Bhai, today's esteemed faculty, Dr. Amar Bhai, Dr. Ravindra sir, Dr. Robert sir. If I look back, then in 2016, an idea came that let us do something so that the people in the comfort of home can be enlightened. And this is how we started. And the first seminar, what Dr. Nitin Shah coined it as, because it was on WhatsApp, it started with pediatric surgical problems. And Dr. Amar Shah, one of our three panelists, he was the one at that time. And concurrently, it was going on all the groups, and more than 600, 700 people, they participated in first session, and that encouraged us. So since then, we have been doing regularly. And in last 1 year, as Nitin Bhai said, this is 12th webinar in a row. I must thank you profusely, Dr. Nitin Bhai, for being there since beginning. And he has been not only there as a faculty, but in our group also. Any common pediatrician practicing periphery, whenever he or she asks, then within 5 minutes he reverts. So profuse thanks. And our group members who has always been self-disciplined, so hardly we face the problems which other groups are facing. I must thank my all Gujarat Pediatrician WhatsApp group members for that discipline. Today we have got a chief guest, an ex-academician, prolific researcher, Dr. Preeti Gali, who is Vice President from South Zone also. So Preeti, bless us with a few sentences of wisdom and inspiration.
Thank you so much, Dr. Bajania. It's a pleasure to be here amongst the masters, and Dr. Nitin Shah leading the masters. And I also consider him as a very, very warm senior and my mentor. It's indeed a pleasure to be here amongst surgeons. And I don't think in the recent past we have had a webinar on pediatric surgery. And I cannot really say how important it is for pediatricians to collaborate and partner with surgeons to know when to refer the child so that the optimal outcomes are there, and also keep updated on advances in pediatric surgery so that both the pediatricians and pediatric surgeons are on the same page. I believe that there have been many advances like biomarkers, minimally invasive surgery, and even robotic surgery. So I'm really looking forward to learning more about all these procedures, and I wish the webinar the very best, and I hope that this series, a very practical series, which touches the heart and mind of each and every pediatrician in the country, continues forever. Thank you so much for inviting me.
Thank you so much, Preeti.
Yeah, thank you, Dr. Preeti.
Let us go straight away to the science.
Yeah, so we acknowledge the presence of other several senior people. We have Dr. Ramakrishna Paramans, we have Dr. Jagdish Chinappa, Dr. Bala, Dr. Jalil, and Dr. Kunal, our friend from Vapi. So welcome, and of course, many of you who are joined on the web stream platform. So let's start today's webinar, and we are going to ask questions, but I'll show some of the slides so that you know what we are discussing. And I will start with Dr. Amar Shah first. Dr. Amar, what are these two pictures? One is a boy who has a swelling in the left side, in and above the testis, and there's a girl which has also got a similar swelling in the left inguinal region. So I will stop sharing here because we want to have everyone on the field. So I'll ask Dr. Amar, when do you suspect that there is hernia? I mean, many times people say there is swelling in the inguinal region, maybe small lymph node, maybe something else. What are the key presenting symptoms which should arouse a suspicion of a pediatrician to refer the patient in time?
So the inguinal hernia is one of the most commonest problems that we see in day-to-day practice. And the most common symptom that the child comes across is when the parents or maybe the grandmother accidentally notices a swelling in the inguinoscrotal region. Maybe while giving the child a bath or when the child is crying. Or sometimes it was accidentally picked up by the pediatrician when he or she undresses the child while giving vaccination.
That's very rare though.
Yeah.
We don't undress. Surgeons complain that you don't undress, we lose our patients.
Yeah. So that is when these inguinal hernias are picked up, and they are mainly accidentally or incidentally picked up.
So this impulse on coughing, Amar bhai, is it really that significant in children, or I mean,
No,
make them
no.
stand and make them
Yeah, so
pressure?
that's precisely why I said that the inguinal hernias are picked up when the child is being given a bath. For example, when it's an older child and the child is standing and the mother is sitting and giving the child a bath, at that time accidentally this swelling or the bulge is picked up in the inguinoscrotal region.
Perfect.
Impulse on coughing for pediatric patients is not very much a clinical sign as compared to adults.
And a reducibility on its own when the child is quiet or lies down.
Absolutely. So when the child is lying down or when the child is sleeping, the swelling completely disappears.
Okay, my next question, is it necessary to do an ultrasound and prove, or it is just a clinical diagnosis and take straight for surgery?
Inguinal hernia as such is a completely a clinical diagnosis, but in today's age and world of legal issues and documentations, it is always, I mean, from the practical point of view, it is always better to get an ultrasound scan done to document whether the child is having a hernia or not. But the ultrasound also helps to pick up if there are any associated anomalies which are internal. For example, the child may be having either a PUJ obstruction or a solitary kidney or any other intra-abdominal pathology which may have gone missing and would have and would be picked up. The second important thing that the ultrasound scan also helps us to know is, I mean, the reason for an inguinal hernia is the patency of the processus vaginalis.
Right.
It is the tract along which the testicle comes down from the abdomen and drops into the scrotum. Now, that processus vaginalis normally should close after the child is born, but if it remains open, then there is a theoretical possibility that the child may develop a hernia in the future. So if the child has a unilateral hernia and the ultrasound scan by a good ultrasonologist picks up a patent processus vaginalis on the opposite side, then even if there is no appreciable clinical hernia, the parents may be given an option, if they agree to consider repairing the opposite side in the same sitting.
Correct. So in fact, that was my next question as to how do you know that the other side is not there? But many times it has happened that you repaired one hernia and after some time it comes on the other side. Parents are very unhappy saying that, oh, you never told us, otherwise we would have done the same process. So I think a point well taken that when you ask for ultrasound abdomen too. So you know any abdominal pathology. And of course, you also ask for the inguinal canal so that you know what is exactly.
The commonest mistake that is done is to prescribe an ultrasound of the inguinoscrotal region.
Only
in a child with hernia. I mean, that is not what is important. In fact, it should be the entire abdomen.
Ultrasonography local karke bete.
Right. So I think now the question, when to operate and whether open or a lap. Parents ask this question so often before even we send them to you.
Inguinal hernia should be operated immediately after the diagnosis, irrespective of the age or the weight of the child. Correct. Now, the approach as to how to deal with the inguinal hernia depends upon the choice of the parents and the comfort of the surgeon. If the surgeon is comfortable doing a laparoscopy, then laparoscopy can be offered. If the surgeon is comfortable doing an open inguinal hernia repair, that can also be offered. So,
when you do a lap, is it not that you can also look at the other side?
Absolutely. So that was what I was coming to, that the advantage of a laparoscopy is that sometimes the patent processus vaginalis may be missed on the ultrasound scan, but at laparoscopy you can have a look whether the internal ring is open or not, and the patent and the processus vaginalis is patent or not, and that can be repaired simultaneously in the same.
Do you always take a consent beforehand that if I find on laparoscopy other side patent process vaginalis, I would operate on that side the same sitting?
I give the option to the parents that if this is the case, do you want the child to be operated on the opposite side? Most
Okay.
of the parents, I mean, almost 95 to 99% of the parents agree that if the processus vaginalis is patent on the opposite side, might as well operate.
Sorry
we
to ask
would-
you this question. Does it mean one surgical charge or double surgical charge or 1.5 times?
I mean,
Because
obviously,
parents are interested in knowing that essentially.
it would be more than the unilateral inguinal hernia, but the selling point would be to tell the parents that it would save you from another admission
Yeah,
and another repeat charge for the hernia. You know?
correct. And as I have understood from my undergraduate days that these are just the patent process vaginal is just a stitch and that's it. There are usually mesh etc. not required, unlike in adults. Am I correct?
Yes, yes, that's absolutely right. Because in children, as I said, the reason is just, I mean, the surgery involves just closing the processus vaginalis, and that is all that we
Okay.
need.
Two more questions that the parents want to know. Will it be covered under the medical insurance? Can you say it's not congenital and acquired?
Well, that's a gray area, you know. I mean, sometimes, I mean, and insurance companies have their own. I mean, sometimes I would say funny criteria of whether to consider inguinal hernia as a congenital problem or an acquired problem. They have these categories of congenital internal problems and congenital external problems, some of which are included and some of which are not included in
No, so
the.
the bottom line is it usually covered or not covered?
I mean, I would tell the parents that we are not 100% sure whether the
Sure.
company will cover it or not. Some companies do cover it left, right, and center, but some companies are very fussy about the
Okay.
hernias.
Last question by the parents they have is that how long the child has to take rest because then they have to time as per the exam or vacation.
Most of the hernia cases are done as a day care. So the child is hospitalized in the morning, operated in the afternoon, and goes home in the evening.
And when can he join school and
He can,
activities?
I mean, he can join school the very next day if
Okay.
he's keen
And
to. Yeah.
activities like sports, lifting, something.
I mean, there are no restrictions for any
No
activities
restriction.
whatsoever.
Okay. Any complication that can happen when you do, or is it's an absolutely safe procedure?
Well, it's a relatively straightforward procedure. I mean, the only complication that can happen, or it's more of a side effect, is that sometimes after the surgery, especially when it's an open surgery, the children may develop some amount of scrotal edema.
Okay.
So that is what you have to warn the
But that's
parents.
for time being, right? It
Yeah,
disappears.
yeah. It's only a
Alright.
transient process. Some children
Alright.
develop secondary hydrocele, which normally disappears on its own. If it does
Okay.
not, then it may need an aspiration. But most of the times, we don't need to do anything.
Okay, now another question. Many times we have preterm babies in NICU and you find there's a hernia. They are about to be discharged. Patient are stable. You operate and then send, or send and ask them to come back as early, or can you delay the procedure?
My advice to the neonatologist would be to get the hernia fixed before the child is discharged from the NIC.
Correct, correct. And it's very safe at in as low as what, 1.5 kilo, 2 kilo
Well,
child?
weight is not a criteria for
Correct.
for surgery.
Should be
for
stable
hernia.
enough.
It can also be done under caudal anesthesia. So there is no need for a general anesthesia to be given.
Okay.
Yeah.
Last question before we close on hernia is female has hernia is very rare. Does it raise a red flag sign that you look at something or it's okay, just operate
Well,
like how you operate a male?
Unlike in males, in females, the inguinal hernias are mainly sliding hernias. And most of the times, the ovary is the content of the inguinal hernia in females.
Correct.
So in females, the thing is that the chances of obstruction are more because the ovary sometimes has a tendency to get stuck in the inguinal sac.
Okay.
So this is what we need to take care about.
All right. And just a passing remark, femoral hernia, they're supposed to be more common in females or?
I mean, femoral hernias themselves are quite rare. The only thing that we need to look from the clinical perspective is that the femoral hernias, the presentation would be below the inguinal ligament.
Correct.
As compared to inguinal hernias, which would be above the inguinal ligament. So that is the only thing that the pediatrician needs to be aware about. I mean, surgery would be again, I mean, closing of the inguinal sac.
So it will be usually an open surgery in femoral hernias or?
Well, I would do an open surgery. I have not seen many femoral hernias because they are itself rare, but
All right.
okay. we would do open.
All right. I think we have discussed enough about the hernia. Dr. Ramesh bhai, please take over the next two. And
yes, Dr. Robert, sir.
Yeah, 1 minute. I'll just show the 1 minute, just so that people know what we are discussing. Maybe we have forgotten to see. All right. Are you able to see it?
Yes.
All right. So, okay. Now this is something different. You have a swelling
Yes.
in the left scrotum, not above the testis, the entire scrotum. And same way you see a swelling which is looking like a round circular swelling in the inguinal canal, and the scrotum is normal. So what are these two things? Go ahead,
Yes,
Dr. Ramesh.
yes, Dr. Robert, sir. What is difference between hernia and hydrocele as Nitin bhai showed both the slides?
So unmute, sir.
So, as
Yes,
opposed
sir.
to a hernia, where there is the patent processes comes all the way down, and there is content which is coming, which may be intestine or omentum. When the opening is very narrow, then it doesn't allow any of the other contents like omentum or bowel or ovary, but water, of course, is able to come across. So when water comes out and collects, that's when we call it a hydrocele. The only difference between the two pictures which you showed, the picture on the left of the screen, is where the hydrocele is within the scrotum. Whereas in the other one, it is what we like to call the encysted hydrocele of the cord, where it is separate. Interesting anecdote is in our Bailey and Love, which we studied, there was a drawing of this Chinese man who had an encysted hydrocele, but everybody thought it was a third testicle. So he was made chief of the village because he was the only one with the third testicle. That's just a true story anecdote from Bailey
So,
and
sir,
Love.
yes, sir. So,
Yes.
humor apart, sir, many parents they prefer to wait. So, like what Dr. Amar Shah said, that hernia should be operated as soon as possible. So, is it same for hydrocele or can it disappear on its own?
Yeah, 80% of them, in fact, can disappear on their own. So therefore, at least the second birthday is the usual cutoff most of us would follow. And they do disappear. By the second birthday, if it is not, it is less likely for it to go away.
So even
So,
an
2 years.
encysted one can disappear, Dr. Robert, or that
Yes,
would
yes.
be...
The guideline is the same. The guideline
Okay.
is the same. And sometimes even girl babies can have a hydrocele of the canal of Nak, though it is rare.
Oh, okay.
It'll look exactly like, as long as Amar said, we should be sure that it's not the ovary which is outside.
Mhm.
And if it is truly a hydrocele, then 2 years is the cutoff. By
Oh.
2 years, if it has not gone, then better to sort it out rather than leave it.
Perfect. Now, you said about encysted hydrocele. Then what is it?
Yes. So again, the canal runs from the deep ring all the way down to the scrotum. When it is open in the terminal portion, it forms a scrotal hydrocele. If the mid portion of it alone collects the water, it becomes an encysted hydrocele. One other phenomenon the parents will come up with is that kabhi chota hota hai, kabhi bada hota hai. So usually in the mornings it is smaller because through the night maybe a few drops have gone back through that patent opening, and so that's
So,
again
Dr.
typical.
Roberts, if I understood correctly, you said the encysted hydrocele gets cut off in between in the canal, but
In
it is proximally open to the perineal cavity, or
Yes,
is it
definitely,
close
because
even?
somewhere it must be like a very small thin track. It may be having like a flap valve, so water will come under pressure.
Okay, right.
And
Okay.
that's why in the night some of it may go, and they will say that morning mein nahi rehta hai thoda.
Correct. And what surgery do you do for either of these hydrocele?
Exactly what Dr. Amar would do for a hernia. The surgery is in fact a herniatomy.
Okay,
Because
fine.
the pathology is the same. Only thing is laparoscopy is not an option for this really because the everything is beyond the deep ring. So we would do an open herniotomy. The incision is still above the groin crease. We don't have to touch the scrotum at all. Whereas in adult hydrocele, they would
Yes.
open the scrotum. Yeah, so
Correct.
that we like to tell the parents that, and somehow they're very reassured when they hear that we are not going to.
Okay.
So, sir, here also one can wait till 2 years. Can it disappear?
The insisted, yes, in both.
Yes.
I think the guideline is the same.
Same.
Hydrocele is 2 years.
Okay. Okay.
Ramesh, I continue the next case also.
Yeah,
I'll
yeah.
just show the slide.
So, Dr. Ravindra, sir, coming to you now.
1 minute, huh?
Yes.
Now
One of
this
the
is-
very common issue, surgical, but many times missed because of lack of examination, right? Like Nitin bhai said that we don't uncover. So it
you
is
can-
undescended testis.
So you can see
So-
the left side of the scrotum is completely empty. Right, go ahead.
So, Ravindra sir, first question is how does one know that it is undescended or retractile testis?
So, retractile testis is something which the testis is normally descended down into the base of the scrotum and it gets pulled up because of the strong cremasteric reflux. So, any method by which you can relax the cremasteric reflux will bring the testis down again. Like when the baby is asleep, when the baby is having a bath, or when if the older child, then if you make him sit in a squatting position, then the cremasteric reflex is overcome and the testes drop down into the base of the scrotum. If you don't see that happening, then it is an undescended testes. Now, ideally, all neonatologists should mention in their every single baby's assessment at the first instance whether the baby has got a hernia or not, whether there is a undescended testes or not, because this can help us in insurance coverage, saying that we have not noticed a hernia before, but now it has appeared later. So it's not congenital. So the fight is between congenital and non-congenital, but undescended testes should not go unnoticed.
So, Dr. Rami, the interesting anecdote that you always say, the oldest you have seen undescended testes, that too bilateral, that too in some doctor himself?
I have seen a pediatrician who is 29 years of age with intra-abdominal testes, still going around with it with a routine ultrasound scans and not trying to investigate further, getting treated.
Oh God! But forget this 29-year-old pediatrician as something which is horrible. But generally, what percentage you see miss, like they're coming at 6 years, 8 years, 10 years, very common, or?
Funnily, today only one of the adult urologists contacted me saying it's a 32-year-old man who has got married for the last 3 years and is azoospermic and he's got bilateral intra-abdominal testes.
Oh God!
So we do get intra-abdominal testes even in adults. And in fact, if you see them beyond the age of 30 or 40, you should just knock out the testes. It's not going to be helpful. It's going to give rise to malignancy, generally seminomas.
Okay, Ramesh, bhai, continue.
Yeah. So if on clinical examination testis is not palpable or even on USG not seen, then is there any role of imaging, sir?
So clinical examination, the repeated clinical examination is what we recommend. Now, ultrasonography is again, as Amar said, we do it for documentation purposes and for insurance purposes that there is the testis is not in the scrotum, and if it is visible, the ultrasound can pick up a non-palpable testis in the inguinal region if the child is very obese, which some of our bottle-fed babies are. So their sonography will pick up an inguinal testis which is not palpable clinically, but the testis which is not palpable clinically and is not visible in the groin requires a diagnostic laparoscopy. Any investigation in the form of CT scan, MRI, testicular venography, angiography, everything is pointless.
Absolutely.
Should not be done.
So here also, rather than writing local sonography local, one should subject for abdominal also, no?
So generally, when you send a child with an undescended testis for ultrasound, they will start looking for that testis and they go right up to the lower pole of the kidney. So that is along the path of the descent of the testis.
So, sir, when I passed out, it was said that at the age of 8 years, child should be operated. So now, what is the current recommended
I'm
age?
very glad that you brought up this issue, because when I was also studying, it was somewhere around 7 to 8 years. Love and Bill used to mention around 7 to 8 years of age. Now the age group has come down. There are some centers who still want to wait till the age of 2 years, but most of the centers across the world would prefer to operate undescended testes between the age of 6 months and 12 months. And there is a reason for it. It has been documented by Hasdi Salimovic, who did extensive studies on undescended testes, taking biopsies before and after orchidopexy. He has shown that the testicular seminiferous tubules actually start developing damages because of thermal differences between the abdominal wall as well as intra-abdominal as well as scrotum, causing dysplasia of the testes and damage to the spermatogonia.
Okay.
So that is the reason why we all believe that the undescended testes should be operated before the age of 1 year.
Oh, okay. So till what age the fertility is preserved?
So there are some studies which have shown that if you operate the children above the age of 2 years, the fertility is not preserved. If you operate them under the age of 2 years, the fertility is well preserved. But I think I would rather operate them before the age of 1 year rather than waiting for 2 years, hoping that some miracle will bring the testes down.
No, that's not the question,
that some
Ravi.
hormonal treatment will bring it down.
Yeah, Ravi, that's perfect. But suppose the child has come late, the parents are now worried, especially bilateral. They want to know, will the testes remain functional? So till what age the functionality, especially spermatogenesis, remains at least to some extent?
So we generally say that we tend to preserve the testes for not only spermatogenesis but also for hormonal purposes, because the testis is going to produce hormones. Particularly if it is bilateral undescended testes, we would like to preserve the testes, with a warning that this testis is likely to have problems like spermatogenesis may get affected if you do the orchidopexy after the age of 2 years. If it is unilateral, generally the incidence doesn't decrease drastically. In normal population, we say that infertility is about 0.5 to 1%. Some centers claim that is up to 5%. But I think in unilateral undescended testes remains almost similar or a little bit less than the normal population. But if it is bilateral undescended testes, then the incidence goes down significantly.
No, let me rephrase the question the other way, Ravi, that at what age you will now not keep the testes, you will remove it?
If it is bilateral intra-abdominal testes and if the hormonal function of the testis is over, then I think the pubertal changes are already taken up and the
Correct.
testes are not good, then we would remove the testes.
Okay, fine.
But again, as I said, this is a very gray area. There cannot be clear-cut guidelines because today you know that everybody wants to have their marbles in the sack.
Correct.
People don't want to lose their marbles.
Okay, Ramesh, we continue.
Sir, any role of hormonal therapy?
Yeah. So as I mentioned, people have studied hormonal therapy, giving them on a weekly basis for 3 months, 6 months, and then assessing the descent of the testes at 3 months, 6 months, and 1 year and 2 years after hormonal treatment. That we used to call it as a medical line of treatment. But as we discussed, that the actual damage to the testes starts to happen after 6 months after birth. So if you want to give hormonal therapy, you're already putting the child for further injury to the testes, and that is what is not recommended. So very few centers, particularly in Europe, will use this as one form of treatment, but we don't recommend it.
So before we close, and last question, Ramesh, one question I want to ask Ravi is that suppose a child is born with unilateral undescended testes, what are the chances that by 6 months to 1 year it will actually come down on its own?
Yeah, so if you look at the incidence of undescended testes in preterm babies, if they are born around 32 weeks or before, the incidence is almost 2%.
Correct.
2% of those babies will have non-palpable or undescended testes, and in a term baby, it comes down to 0.8%. So 0.8% will go down further to 0.5%. So that is the reason why we say that wait till the age of 6 months. And since there is a documentation that the damage to the testes starts to happen after the age of 6 months, there is no harm in waiting till the age of 6 months.
And
lower the
testes in the inguinal canal, more are the chances of it descending on its own, or there's no rules like that?
Generally, yes, because the testes will move one station at a time. It won't kind of descend directly from the abdomen into the scrotum within a span of few months. So it will go one station at a time. Another important thing to remember is if there is an associated hernia, then the baby, if he's got an undescended testes, then orchidopexy should be done at the same time as herniatomy and should not be left for 6 months.
Perfect.
And another thing is an acute scrotum or acute inguinal swelling in babies with undescended testes. Be very careful that you're not missing on a torsion testis in an undescended testis, may require emergency surgery. So that is something which is an important thing to remember.
Right.
Ravindra sir, finally, what is the risk of malignancy? We all know that fertility is affected, but what about malignancy?
So the risk of malignancy varies as per the age of the treatment. Normal population, the risk of testicular cancer in India is supposed to be 1 in 1 lakh. Whereas in Western, that is about 1%, whereas in Western countries, the reported incidence is about 2.5%. So we already have a lesser incidence of testicular cancer. At the same time, if the testicular undescended testis is treated in time, then the chances go down further. Like patients who have undergone orchidopexy below the age of 2 years, the incidence is about 2%. But if you wait till the age of 30 years, the incidence is almost to the tune of 12 to 15%, in some series up to 30%. So it goes up by 3 to 7 folds. So that is the reason why we say that do the orchidopexy as early as possible, so that in case there is any risk because of delayed treatment, we kind of negate that.
So as I understand, Ravi, you're saying that even if you have done surgery in time and brought down the testes and stitched it to the scrotum, you still need to follow up these children because there can occur malignancy more than in the general population, even after you have brought them down. Is that correct?
So if you look at the epidemiology of undescended testicular cancer, about 10% of patients who develop testicular cancer will have a history of orchidopexy or some surgery done for undescended testes.
Okay, perfect.
Nitin,
all right, let's change the gear and I show the next slide. All right, so we saw this. Dr. Amar, what is this? This is an acute symptom, pain, little redness, irritable child, and unless you strip, sometimes you may miss it. So
this is an acute left scrotum. There is a swelling, redness, and which is seen on the left side of the scrotum. The testis is not separately seen from the swelling and the redness. So this would be an acute scrotum, and most likely this would be a torsion of the testis.
So how will you know it's torsion and not epididymoarthritis?
Well, the golden rule that is there for all pediatric surgeons is that any acute scrotum is testicular torsion unless proved otherwise.
Correct. So how will you prove the otherwise?
Well, there are, either first and foremost, it's a clinical diagnosis. In an acute scrotum, the history would be sudden. it would be a healthy child. There would not be any history of fever or urinary tract infection. And the swelling suddenly develops. The child would have episodes of vomiting, or if it's a slightly older child, there will be some amount of lower abdominal pain also on the left. On clinical examination, the testis, the scrotum would be red, swollen, and the testis would be very tender on examination. And it would be predominantly a unilateral pathology.
Correct. Why is it a medical emergency? I mean, how much time you have to really
Well,
solve this?
testis basically the testicular artery is an end artery. So if there is no as such collateral supply to that testicular artery,
Correct.
if there is a twist, then the maximum that you can get is 6, and if you are lucky, then maybe 12 to 18 hours to save the testis.
Correct. So is there a need to prove it by imaging, or you just take him up for surgery? Because you have very little time. Suppose night the child has come crying and you faint, you can't do ultrasound till next day morning and wait.
So again, yes, this is an important question. I mean, if the child comes in the middle of the night, if there is an acute scrotum, there is no point waking up the ultrasoundologist and to wait for him to come and open his clinic and do the ultrasound or the color Doppler. You can straight away go and operate the child. If the child comes during your consult in good
morning hours,
if you have an ultrasoundologist which is available on hand, then it might be worthwhile getting the child examined by an ultrasoundologist on an urgent basis.
So you do a
some amount of
Doppler also to show the flow, or just the ultrasound to show the anatomy?
No, the ultrasound always accompanied with the color Doppler.
Color Doppler, okay,
Yes.
fine. And that will show sluggish or no flow, and then you know you're dealing. Is ultrasound 100% sacrosanct to diagnose?
No, if there is a strong clinical suspicion, even if the ultrasound scan does not show, then you may not be wrong in going in and exploring the child.
So what do you do? You explore, and what do you do in surgery?
We put a scrotal incision, deliver the testis, examine the testis. If there is a twist, then we have to untwist the testis. Because the twist is normally towards the midline, so we have to untwist it on the opposite side. And then wait for the color of the testicle to improve. I mean, if there is a torsion, then invariably there will be some amount of vascular compromise that the testis would have undergone. So once we untwist the testis, we ask the anesthetist to give 100% oxygen. We put the testis in hot packs of warm saline, and then wait for the color of the testis to improve.
So how long you wait before you take a decision that now it's salvageable or not salvageable?
Well, we wait for about 10 to 15 minutes.
15 minutes.
And then by that time you can get an idea of how things are going. Still, to get a better idea, you can even put a small incision on the tunica and see if there is frank bleeding or not.
Okay. And then what do? You fix that?
So if the testis is viable and it's a salvageable testis, then we fix that testis so as to.
What about the other side?
Yes, the other side also needs to be fixed because
same sitting.
Yes, absolutely, on the same sitting, in the same sitting. So sometimes when there is a testicular torsion, while you are waiting for the color of the testis to improve, it may also be worthwhile to deliver the opposite testis and start fixing it, you know. So you make good use of the time.
So you reduce the anesthesia time.
Absolutely.
You
just have to wait. So might as well fix the opposite testis during that time.
Okay, I'm going to share now. We move to the next condition. Dr. Roberts. What is this? There are two things. One, I see the whole umbilicus is out, and other way I see the swelling is above the umbilicus.
Yes.
So my question is, what is umbilical hernia and what is paraumbilical hernia? I mean, what's the difference?
Sure. Just before I go on to the umbilical area, just a comment, you're talking about torsion.
Please, go ahead.
There's also a lesser commonly seen torsion of the ovary. Many times the gynecologists don't agree with the diagnosis. They say in children it doesn't happen and there is a dual, but it's a very real entity. The only difference between the testicle and the ovarian torsion is the ovarian torsion is more forgiving. Nature is more kind to the ovary. So even if it's a 24-hour history of torsion, very rarely will we take it out. We will still untwist it and preserve it. So just wanted to highlight that.
In fact, before you go to umbilical hernias, Ravi will be smiling. He just operated on a twisted ovary and the salpinx just last week. Is that Ravi correct? Unmute.
It was a 3-day history. It was completely infarcted. There was blood in the peritoneum, so there's no point in salvaging that
Oh
kind
God,
of
you
thing.
couldn't salvage it. Okay, go
No,
ahead,
so
Dr. Robert.
the other thing that we need to make the ultrasonologist also aware is that in any girl with acute abdominal pain, especially acute lower abdominal pain, they normally don't try and see for the uterus and the ovaries as a
Correct.
routine.
Correct.
So whenever you send any girl, any adolescent girl or any teenage girl with acute lower abdominal pain to the ultrasonologist, always make sure that you phone him and inform that please make sure you see the ovaries and the uterus, because they invariably try to avoid it because they
It
don't
is-
consider that to be a part of the abdomen. They consider that to be a pelvic.
Yeah.
So Amar, there
I
is an
think it is
interesting scenario.
unfortunate that you send a CBC to the pathologist, he doesn't see the pelvic smear. It is a crime. Same way, if sent for an ultrasound, it doesn't do pelvic examination. I mean, I always write ultrasound abdomen and pelvis at least in a girl child. Let him chat a little more if you want, but give me the correct diagnosis. I mean, that's what I
Absolutely.
want.
Nitin
Right,
bhai, you may
Dr. Robert,
remember.
go ahead. Sir, yeah, Ravi?
Ravi.
Nitin bhai, you may remember that we had a similar situation a few months back where there was an ovarian cyst with an acute abdomen. Everybody kept on talking about this being a torsion. Doppler, CT, MRI, everything was done, and I put a scope inside. Actually, it was an appendicular mass. Appendicitis is completely missed. Everybody focused on that large ovarian cyst.
Right. So many times an exploration actually helps you to achieve the diagnosis. Though 9 out of 10 times you will be right before exploration. 1 out of time you will be surprised when you actually open up.
Yes.
Yeah, Dr. Robert, my 2 patients.
Yes. So the picture on the left, your standard classical umbilical hernia, that is a patent umbilical ring, which we know is extremely common, and typically when it comes through the central part of the belly button, like a flower, then usually most of us would wait until the 3rd birthday before you correcting it, because again the magic number of 80% getting better by itself by the age of 3.
By age of 3. So you will wait for surgery till age of 3 unless they become complicated.
Yeah, with the exception that it gets an obstructed.
So larger hernias are less likely to get obstructed as compared to smaller hernias. Is that true? Like the ring sizes?
Yes, the chances of a larger defect, which is usually bigger than when my thumb goes in or 3 centimeters, is less likely to get obstructed, but it's also less likely to close. The larger, the less likely to close.
Okay.
Whereas the smaller ones are at a higher risk. It's logic for your preterm inguinal hernia. The smaller the baby, smaller the defect, higher chance of an obstruction.
Correct. Many times it is seen that they don't have it at birth, but as they grow and suddenly they put a lot of weight, then suddenly they see an umbilical hernia coming up. What is the reason? I mean, is the pressure of the intra-abdominal content, or what is the reason?
Not really, sir. Parents ask this question all the time. They're saying it was not there. It's come now at the age of 2.5. But the door was open from birth. The robber did not come into the house. Basically, you can't question the robber. Why did you come 2 days late? that is what I tell them.
Right.
The picture on the right side, that is a different kettle of tea.
Correct.
That is either a para-umbilical or more commonly it's on the top, so it's a supra-umbilical. So these
see, unlike the umbilical hernias which disappear in most, para-umbilical will never close.
Will highly unlikely to close because it is not a physiological opening. Whereas the umbilical hernia was a physiological opening. It is part of development.
So what is the reason for para-umbilical or supra-umbilical? Is there a defect there, or it is?
There is a defect. There's an actual defect, basically because the way the mesoderm forms in the midline is both structures come in from either side and they fuse. This is one location where it did not fuse, and there's a small defect. Sometimes it is like you showed, sir. It is a hernia with bowel coming. More commonly, it might just be fat also coming, epigastric fatty hernia, which we say. My own son had it, and I decided to manage him conservatively till the age of 7 years because I said, "Main to hoon," and then finally we obstructed even with that. Then I had to go in an emergency and operate. So.
Correct. Common mistake parents do, they want to tie the umbilical hernia. I mean, what is your message to them?
Yes. So
put a coin or put something or
put a
cloth or something.
Or they get this medicated some plaster which they put, some sikka which they get from some holy place. And all of these, I think, are more dangerous than not doing anything. I don't tell them because
the hernia can actually slip between the skin and the coin.
Between the coin and then get obstructed or get a vascular compromise because of that. So that's an absolute no.
So if you have a
Amazon, is part of the problem, because Amazon sells these umbilical belts and umbilical trusts now, which is reaching patients without any prescription. And I've seen children coming with an oversized, like for the inguinal hernia too. So I think this thing needs to
even for babies.
For children, yeah. For children.
My. All right. So you said that supra or parambilical hernia are unlikely to close. So then when do you operate? As early as possible when they're diagnosed, or give some time?
Very difficult question, sir. Very difficult question. Because if you see it in a child who's less than 1 year, I still counsel them and I say, come back and see me at about a year.
Okay.
It's not a desperately urgent situation.
And
what do you think, Ravi?
Yeah. Unmute, Ravi. I think you can all keep unmute, Dr. Amar, Ravi. You need not mute yourself. It's okay.
So if you have bowel that is herniated out and not the fat, then I think it makes sense to operate, because generally defects are small and then they are likely to create complications. But if it is just a peritoneal fat that is popping out, then you can wait for a few years.
Correct.
Till the child actually complains that there is pain or some discomfort or something, or dyspepsia, whatever may be the symptoms.
Correct. So Dr. Roberts, what do you do for the umbilical, parambilical? Just open up and take 1 or 2 stitches. Is as simple as that?
It's an anatomical repair. Then there is no mesh, there is no role for any of that.
And most of them never recur, or none of them ever recur?
I would say 1 to 2%, just to be on the safer side.
Generally, they don't recur.
Okay.
The recurrence would be more when it is present in syndromic children.
All right. Okay. Dr. Ramesh, now take the next case.
So, Robert,
we saw this. Now,
regarding that
what is this?
hernia, what is the risk if left untreated?
The risk of obstruction, sir. The risk of either bowel or omentum getting obstructed and then going to strangulation, like in an inguinal hernia. That would be the biggest problem.
Okay, Ramesh, my next case.
Now coming to Ravindra, sir. Very important topic, hypospadias. So what are the different types and how do they affect the patient and surgical outcome?
Yeah, so that's a very good topic to cover. It can itself consume more than 2 hours in discussion, particularly when 3 surgeons who are interested in hypospadias are sitting there. So basically, for simple reasons, we say that hypospadias is one of the very common anomalies. If you look at the actual incidence, it's supposed to be about 1 in 300 live male children. So that's a frequent incidence. We don't get it picked up because of variety of reasons. The commonest of them is distal. The distal includes glandular hypospadias, coronal hypospadias, and distal penile hypospadias. Then you have midsection, which is called as a mid-penile hypospadias, and then you have a proximal section where you have a penoscrotal hypospadias, scrotal hypospadias, or a perineal hypospadias. So the go more proximally, they become more complex and much more difficult to treat with significant issues with them. The distal hypospadias, which we all repair in a single stage, and the success rate is almost 95 to 98% with most of the whatever techniques people use. There are a variety of techniques that are described for hypospadias. For proximal,
so when do you operate, sir?
Pardon me?
When do you operate?
So generally around the age of 8 months, I prefer to operate hypospadias. The reason for that, after hypospadias repair, we put a catheter in these babies, and the catheter drains either into a bag or into a diaper. Now, around the age of 8 months, the child is just about sitting, is not walking, not running around. So if you delay it beyond the age of 1 year, then the child is already mobile, and it is very difficult to maintain the bags or to maintain the diaper and the cleanliness of the thing. So I prefer to operate them somewhere around the age of 8 months. And
so how long does the catheter remain in place? 2 weeks?
So it depends on the type of operation you do. Again, it depends on the complexity of the problem. So distal penile hypospadias, 1-stage repair, catheter will stay for a week to 10 days depending on the operation you do. One very minor operation which we need to do in some patient called as MACPAT doesn't even need a catheter, but we may keep it for about 48 hours. In more proximal hypospadias, they are done in 2 stages, where you first do the correction of chordae, release the urethra, because the urethra just goes on receding. You straighten the penis and then use some sort of additional tissue, either the preputial skin, inner preputial skin, or a buccal graft or something to replace and recreate the urethra at a second stage, which is done after 6 months. So when you do it in 2 stages, in first stage, you keep a catheter for about 5 days till the stitches are clean and healthy. And the second stage, you'll keep a catheter for about 10 days to 14 days, depending on how long the tube has to be made and whether you need any additional urinary drainage procedure. Some people prefer to do a suprapubic cystostomy also in a very complex hypospadias, which is kind of a perineal hypospadias.
Perfect.
So what is the risk of failure, sir?
So risk of failure increases as you go more proximally. As I said, the distal penile hypospadias, generally the success rate is 95%. The mid penile is somewhere around 85 to 90%. If you go to penoscrotal, it comes to almost 70 to 80%. And if you go to perineal hypospadias, I think the complication rate is more than 50%. Correct me, guys, if I'm wrong.
Anyone wants to add, Dr. Amar or Dr. Anthony, on this hypospadias?
The only thing that we need to say is that in any child who has been born with a hypospadias, you should always advise the parents against circumcision. I mean, repeated circumcision should also be avoided in children who are born with hypospadias.
Correct.
Yeah, because that preputial skin will be helpful for us in reconstruction.
Yes. Dr. Robert, you wanted to say something?
Yes, another common question which parents ask when they come in practice is, why is this so common? And actually, if you see, the incidence is on the increase. It wasn't so common when we were studying, but it's much more.
What's the reason?
Worldwide, it is common.
The reason?
It's probably it's a feminization of the male genitalia, and the side effect is probably environmental pollution with a lot of pollutants which are there. It's there in the milk. It's there in the groundwater. It's there in most of our preserved foods. Those are sprayed with chemicals, and those are very weak
Estrogens.
That increases the profit of the company. It increases, the bottom line. It's going to finish off our human race. Yeah.
This is scary. This is really scary.
Sir,
counts also are going down world over because of this in every country.
Hypospadias has exponentially increased in the last few years. Exponentially.
Okay. I think Dr. Roberts has to. Yeah, Dr. Roberts has to leave. So before you leave, sir, I'm going to take the next question with you, so that then you can go for your.
And thank you for sensing my restlessness.
I understand. So I will just go through this. These are the two cases where there is a severe swelling at the tip of the penis, redness. The other one is the entire prepuce and the shaft is looking red. So what are these cases of phimosis and paraphimosis? If you can explain.
So both of them have a very narrow opening from what I can see. The skin is inflamed, and typically the history will be child was fine, and then now he's crying when he's passing urine. And frequency, there'll be small dots. Sometimes when you just touch the prepuce, you'll get white, dirty secretions which are coming out.
So that's because the balanoposthitis, or?
Yeah, so it's balanitis, and going on, it becomes a balanoposthitis when the shaft also starts getting involved. I don't think either of these was a paraphimosis.
Okay, so now what is physiological phimosis? I mean, every baby is born with a very small meatus.
Yes.
Parents are worried. We keep on telling them no worry. Till what age? I mean, UK guideline, one is to say that up to 18 years you need not operate if there's nothing else.
I would say it takes up to 3 to 5 years if the child is fine, if the child is not having any infection, these redness episodes, then it's still physiological.
So when would you say it's now turned pathological is when they develop recurrent infections?
Recurrent infections, or you're getting scarring on the skin because the child is trying to open it, or somebody else is trying to open it. You get a stellate scar. You get.
What about ballooning? Some others say there's ballooning, but otherwise the child is absolutely all right. So would it mean need to intervene early, or?
I don't think so, because in fact the ballooning is, I think, nature trying to fix it up. Unless there is a symptom. If there's ballooning with frequency, ballooning with redness, then of course we'd like to open it up.
So many times the parents want to try some medical treatment before they would say surgery. And you also said you would wait for 3-5 years if there has been not much infection, but the parents want to do something. So is there any role of stretching exercise? If yes, how to stretch it? A role of local steroid, which steroid and how long?
Yeah, so I think all the 3 surgeons on board here will probably not like to operate immediately. We all like to give them a chance of a steroid. What I use is Betnovate, but there are many other choices. Basically, weak steroids, max for a month or 6 weeks that we use it for. And I don't encourage the manual stretching at all, or the massage as the parents sometimes call it.
It should be discouraged because it can lead to more scarring with bleeding.
Yes.
Yeah, I think this message needs to go to the pediatricians, because I've seen a lot of patients coming saying that our pediatrician has told them to pull the skin and apply some olive oil or whatever kind of oil. And every day in a bath, you must pull the skin back. So I think pediatricians request to all of you, please don't advise these kind of things.
So you said
that's causes scarring.
Yeah, so you said
Can I
wetness.
take leave, please? I'm so sorry. My
No
apologies.
problem, Doctor Robert.
Yeah,
We'll
yeah.
continue. All the best for
Thank
your
you.
Thank you so
humanitarian
much. All
work.
the
me.
best.
Thank you,
Thank
Robert.
you. Really honored to be part of this.
We appreciate your humanitarian work, sir. Please,
Good work.
thank you very much for joining. God bless
Thank
you.
you
Have
so
a
much.
safe
Have a
journey.
safe journey, sir.
Thanks, Robert. Bye-bye.
Thank you.
you.
Thank you, Amar.
All right,
Thank you.
so maybe Amar, I'll continue with you.
Yes.
You avoid pulling the prepuce up and down because that can lead to more scarring and bleeding. So when you apply the steroid, you said either betanovet or betamethasone or mometasone. You apply exactly how? I mean, you apply it around the prepuce or at the tip of the prepuce. And how long?
It has to
Massage
be
or whatever?
basically, there are two types of phimosis. I mean, one is the picture that you showed where the prepuce is conical and narrowed at the tip.
Correct.
Okay, and the second is a non-retractile foreskin where sometimes what happens is that the opening at the tip can be widened, but then there is a ring around which is
Correct.
preventing the prepuce from going over the glands.
Correct.
So that is the variety which is called a non-retractile foreskin. I mean, it's a fancy word for a plain and simple phimosis. But when there is this ring which is causing the foreskin not to retract, I normally show it to the parents and ask them to apply the steroid cream around that. On that narrow ring and then to rub it. And I
In a
ask them to do
circular
it.
manner, again, not a vertical up and down type.
No, I mean, ideally it should be in a circular manner, but the people who are going to do this exercise are going to be the mothers, you know.
Correct.
So
And you apply what, twice
they
a
are
day or
going to
just
apply
once a day?
Yeah, twice a day for about 6 to 8 weeks. I give them a decent chance of about 6 to 8 weeks before taking any decision.
And suppose it is helping them, then you do continue. The parents
Yes,
cannot.
absolutely.
How long maximum?
At least for 3 months it can continue. There is no harm in doing that.
Okay, fine. Now, which ones to operate? Is there?
When there is a very tight phimosis with scarring, that is called BXO, balanitis xerotica obliterans. In those patients, we go for upfront surgery. Children who are having episodes of recurrent balanoposthitis.
Okay.
Then children with vesico-ureteric reflux who are having recurrent urinary tract infections.
Okay.
In them, even if there is no phimosis, we do offer a circumcision because it's shown to have a prevention in breakthrough urinary tract infections. High grade
As a corollary to that, in past, some surgeons some pediatric surgeons used to say that a child having recurrent UTI without any VUR also may help because the hygiene is not good, just circumcise them. Is that any more?
I mean, that is a slight overdue. I mean, circumcision has shown to prevent breakthrough urinary tract infections. But nowadays, we don't do it just for simple, uncomplicated urinary tract infections, you know. Yeah.
Okay, parents also want to understand that now their child is better. What hygiene precaution they should take for a small child or teach to an older child, as far as genital hygiene is concerned?
I would not advise the parents to daily retract the prepuce and clean in an infant.
Okay.
Or I mean, once the child is about 7 to 8 years old and is capable of retracting his prepuce himself while taking a bath, only then is the time to, in fact, advise them to maintain preputial hygiene. Till then, if the mother and the father are competent enough or are sensible enough to do it in a gentle way, then yes, it should be done at least once a week. But if they are not confident, if the child is a bit too grumpy, then it would cause more of a damage than of a help.
Okay, last question, Dr. Ravi. What is paraphimosis? Why would it happen, and how can you prevent it, and what treatment is done?
So as Amar was mentioning that there is that fibrous ring in the foreskin. If you pull the foreskin forcefully back in an attempt to dilate it, the skin will sometimes get stretched. It will break the scar cicatrix and go and get stuck behind the corona, which is the terminal part of the glans. And that is the coronal sulcus. The foreskin gets stuck and then it becomes edematous and becomes very painful.
Correct.
And so it has to be treated immediately.
So can you reduce it, or does it always need surgery?
No, many times you are able to reduce it if the child comes early to us. So many times we would ask the parents to come, bring the child immediately to whichever hospital they are closest to their home and get it reduced. If they are able to reduce it without anything, then very good.
No, how does the surgeon do it? Like, so I send you a patient, what do you do? Like, you put some warm packs, or I mean, how do you do it?
The ideal thing would be to give some sedation to the child, apply some local lubricating anesthetic cream, and then gently use pressure to push the glans behind the foreskin. But it can be painful if it has been there for a long time. If there is a lot of edema of the foreskin because of the paraphimosis, then you may have to do needle puncture and deflate the edema before you are able to kind of pull the skin back.
And
If you are
generally,
still unable to do it, then you may
Yeah.
have to surgically release that fibrous band at that point of
Correct.
time, and
Correct.
then do a circumcision at a later date.
so generally, what percentage would be like in what time of period after they have noticed the first symptom, you are able to generally reduce it without immediate
Most
surgery?
of the patients today, we are able to reduce them.
Most of
I
the
have not
patients.
done a
Okay.
single kind of a emergency surgical procedure for any paraphimosis for many years now.
All right, let's move to the next. Dr. Ramesh bhai, you can start. So 1 minute, huh? I'm going to show the pictures.
Umbilical granuloma. should
1
be
minute,
seen.
yeah. So now there are three things. There
Amar
is
bhai,
one there is a redness in the center. The one there's something protruding which is red in the center. And there's something which is really protruding like an organ. So Ramesh bhai.
So coming to you, Amar bhai, what is this?
Now, there are three images. I mean, the first image on the left shows there is an umbilicus which is chronically infected. The most common reason would be there would be some discharge which is coming out of the umbilicus, which is keeping the umbilicus wet and which is causing this excoriation of the umbilical skin. Found the cherry-like structure which is seen coming out of the
1 minute,
umbilicus.
Amar bhai, we
And
lost you for some seconds. So can you repeat what you said?
in the first picture on the left,
Nitin bhai, show the picture simultaneously, please.
Okay,
pardon?
I will.
Yeah.
1 minute, I'll show. Just 1 minute.
Yes.
Okay.
So in the first picture on the left, there is the girl child. There is an umbilicus which shows chronic omphalitis. I mean, there is a
Correct.
excoriation of the periumbilical skin which is seen there. And the most common thing would be some discharge which would be coming out of the umbilicus over a long period. This is quite an older child, so there would be an umbilical discharge which is coming out since quite a long time, which has caused this excoriation.
Perfect.
In the middle, you can see there is this cherry-like structure which is coming out from the umbilicus, which would likely be an umbilical polyp. And in the third structure, I mean, you can see a dimple which is there from what looks like a tiny intestine-like structure which is coming out of the
Yes.
umbilicus.
Yes.
Now, this could likely be a patent vitalointestinal duct on the right. The middle structure would be an umbilical polyp. And to the left would be a chronically discharging umbilicus. It could be either a deep-seated umbilical granuloma or a patent urachus.
Correct.
So treatment of umbilical granuloma, because there are so many options and common salt has been recommended. But when I started my practice, one of my colleagues said that the local application of steroid also gives good result. So
Well, yes, I mean, nowadays common salt is the go-to treatment for umbilical granuloma.
So-
And most of the time it gives very good results. That the granuloma just disappears or it shrivels off on its own.
So can you elaborate as to which salt and how long, how many days, etc.?
I mean, I just asked them to put a very small pinch of common salt over the umbilicus once a day, and we asked them to come back after about 15 days and see how the response is. And most
Just
of the
one day only, or if they continue to apply?
I asked them to put it just once a day. I mean, once a day would be more than
So
enough.
once a day for 15 days.
15 days, yeah.
Okay.
And I mean, if the granuloma disappears, then they can stop. Otherwise, no.
simply sprinkle this salt and no bandage, because I have seen children coming with bandage also with salt inside.
I mean, basically, it just needs a few granules of the salt to come in contact with the umbilical granuloma for the action to take place. Basically, it's sodium chloride, and so no sooner it comes in contact with the granulation tissue, it will cause a reverse osmosis and it will cause shriveling of the granulation tissue, and then it causes the granuloma to disappear.
Correct.
So any
basically
role
it
of
is hygroscopic.
Yeah,
It
yes,
doesn't
sir.
have any
Hygroscopic
chemical
action, yeah.
It
just
will dehydrate
hygroscopic.
the
So,
umbilical granule.
interestingly,
Exactly,
in
exactly.
rural
So-
Scotland,
so any
they
role
use
of-
sugar instead of salt.
You can add sugar.
They use sugar instead of salt in rural Scotland.
I know, but
That's
the
one
only problem
interesting-
with sugar, where the infection rates are higher, or there's
No,
nothing.
nothing at all.
All
Nothing
right,
at all.
good. Okay.
So Amar, any role of chemical or electric cautery?
Well, I mean, the granulomas who do not respond to these conservative measures, then yes, chemical cauterization or this electric cauterization can be offered.
So which chemical cauterization?
Silver nitrate is used.
So with
Silver nitrate sticks.
with the
Copper
with the,
sulfate, I'm not seeing copper sulfate, but silver nitrate sticks I have seen, yes.
okay, so is they available easily?
The dermatologists have those silver nitrate sticks.
Okay, fine.
Mhm.
Ravi, have you used this silver nitrate sticks anytime?
Long time back.
Okay, are they available easily or?
I haven't used it for last 10 years plus.
So if
I have no idea.
if the salt fails,
Must be
then
available.
probably electric cautery would be the
Yeah,
easiest
yeah.
option. And who
Just a
does it? The
white colour.
surgeon does it or the
Yeah, you need to
Surgeons
have a cautery.
would
And
have
most
the
of the
electric
surgeon
cautery,
would have
yes.
a cautery. So you would
Okay,
either
fine.
use a monopolar or
So
bipolar is
salt
probably the best
hardly
option.
fails.
no, salt
Ravindra sir,
hardly
because you are
fails.
not done in last 10 years, so salt hardly fails.
Yeah,
Okay,
it does.
okay.
It does. Salt or sugar,
Now,
whatever you want.
now coming to third slide, Amar, when do you suspect it is patent retinal intestinal duct?
Well, there is I mean, if the child goes beyond the neonatal age and there is still umbilical discharge which is persistent, and on clinical examination you cannot find any umbilical granuloma or umbilical polyp or a structure like that in the umbilical scar, then you have to suspect that the child has got either a patent urachus or a patent vitalointestinal duct which is causing leakage of either urine or intestinal contents through the umbilicus.
So once you suspect, what do you do further?
The first would be either to do an ultrasound scan to see whether the ultrasonologist can pick up the patent urachus or whether there is a urachal cyst inside sitting over the bladder. Sometimes they may pick up a Meckel's diverticulum with a band which is connecting with the umbilicus, very less likely. But then, if there is nothing that is found on ultrasound, the diagnostic and the therapeutic measure would be to do a laparoscopy. Laparoscopy is diagnostic, and at the same time, we can treat the pathology as well.
So what do you do in patent urachus procedure?
If there is a patent urachus, then the urachus can be disconnected laparoscopically and it can be closed. If there is a patent vitalointestinal duct, then that also can be tackled. That through the umbilicus, that patent vitalointestinal duct can be delivered, and that part can be resected, and end-to-end anastomosis of the intestine can be done.
All right, let's move to the next condition.
So
Again,
sometimes you get an infected vessel also. I have had few patients where the umbilical artery was the source of infection, and the sinus on exploration on injecting the methylmalate, we could actually go right up to the origin of the left umbilical artery and excise the entire thing and the excretion stop. So sometimes it can be a vessel, umbilical vein, umbilical artery, particularly the child has been catheterized in the neonatal age for whatever reason. If there has been
Yes,
umbilical
absolutely.
catheter, then they would be one of the reasons to have this discharge.
all right,
So
let's
yeah.
move.
Infraumbilical cyst can also get infected and may lead to a similar problem. Yes, absolutely.
All right, let's move to the next thing, Dr. Ravi. This is very common. There is a
Yep.
tongue tie, and when they protrude the tongue, it's like a snack fork, and the parents are worried. So my question: is tongue tie ever a cause of delayed speech, or it is just a physiological defect and best left alone?
So that's a very difficult question to answer. You know that. The reason for that is people have done tongue tie release and the speech has not improved.
Correct.
And there have been situations where tongue tie has been released and speech has improved. So it's an impossible question to answer.
Correct.
But yes, if it is a very tight tongue tie with a very tight fibrotic frenulum, then you need to release it. And once you release it, then the child needs to undergo speech therapy, tongue movement needs to be taught to the child, and then the speech may improve. So there is no foolproof evidence that yes, you do tongue tie release and the speech will
So
miraculously
if there
become
is
normal.
no speech problem, can you do it only for the cosmetic reason? The child doesn't like, no, my tongue
So there are
pokes when
two
I.
other reasons why you need to operate on tongue tie. One is a feeding problem, that the neonate cannot breastfeed properly because the tongue tie is too tight and the tongue is
Correct.
completely plastered, so cannot suck onto the breast properly
Correct.
and push and gulp down the bolus of milk that comes down. And the
Correct.
second reason would be that there is cosmetic problem with it, that the tongue actually rolls on itself and the tip never comes out.
Correct.
So that is the situation where you would consider doing a tongue tie release.
So what do you do actually? I mean, it's a very simple procedure.
It's a very simple procedure. If you are a pediatric surgeon, it's a very simple procedure. If you are a plastic surgeon, it's much more complex procedure, because then you would intubate the child, put a throat pack, do a surgical repair of the entire floor of mouth and suture it. But for pediatric surgeons, it's just a snip
So what
and
do you do?
inject some
What do you
local
do?
anesthetic. You
Uh-huh.
snip the frenulum, protecting the opening of the ducts
Uh-huh.
over there, and stretch the tongue to make sure that it comes up to the lowermost border, lower lip vermilion border, so the tongue movements are free.
So are there any
Generally, no stitch is
stitches?
required. Generally,
No
no
stitch
stitch
is
is
required.
required. If there is any oozing, then we may use a bipolar, and we would infiltrate local anesthesia so that the child is completely pain-free post-op.
Can the dentist also do this procedure?
Yeah, that's a new trend around the world. So dentists are using laser for dealing with tongue tie and claim miraculous release of tongue with speech becoming normal. They're also doing something called as lip tie. So there is a frenulum of the upper lip which they are releasing, saying that this helps in the dental growth and the teeth remain in alignment properly. So that's something which is beyond understanding for me.
All right. So most of the time, tongue ties, unless they are symptomatic, as what Ravi described, major are feeding issues. Then are the problem of able to swallow. Then comes the cosmetic. Speech is very plus minus, as it can be either way. There are many deeper reasons for speech delay in such children. All that taken into consideration. Yes, if someone wants, is a simple procedure to release the tongue tie. All right.
The
Let's.
child,
Yes.
child with
go
the
ahead.
tongue tie cannot lick an ice cream.
Yeah.
Yeah.
No,
Okay.
Nitin, on the humorous side, there is a temple near Gandhinagar where children with delayed speech are cured with the blessing of Mataji.
Okay.
Kotla Mataji.
Oh, I see. Okay. Okay, Ravi, we continue with you.
Okay.
Now, this is a female child, and many times mother is worried. They keep on saying when bathing the child that they can't see the vaginal opening.
Mhm.
And on the right hand side, you are seeing a child
A
with
dimple. Yeah, there is a dimple.
So what is this?
So the image on the left side is what is called as a labia minora synechi, or fusion
Correct.
of the labia, which
Correct.
kind of is a healing, or the way the development has happened, that the labia has not separated itself. And that can give rise to certain symptoms in the form of pseudo incontinence, because the urine collects in the vagina and gradually leaks out to a tiny opening.
Correct.
Or there can be urinary tract infection.
Correct.
Generally, it doesn't require any treatment, but if there is symptoms which are like this, like pseudo incontinence, or child is having urinary tract infection, then you need to separate it, and there can be medical management or a surgical management. So medical management is by using estrogen cream, which can be applied locally. Gentle application of the estrogen cream on the fused area of labia minora will allow it to gradually separate, and you don't need to do anything further.
So how
and
long
the cream
you
needs to be applied
try
twice a
that?
day for at least 6 to 8 weeks,
Which
sometimes
one
up to 3 months.
Which one brand name any?
Do you
So
also
primary-
try to separate it in between, or just apply 6 to 8 weeks and
So
then
if
try
you
to?
are using cream, then don't try to separate it. If you want to separate it, then you don't need to use the cream.
Okay, fine.
So which creams are any brand?
So estrogen cream, primary.
Yeah. Okay. All right. And suppose you have to operate, and what do? You do radiolysis, like how do you? Is
So
local,
we just
under
separated
local,
it. Yeah, so it depends on the age of the child. If the child is older and cooperative, then we can even do it on an OPD basis in the clinic itself, apply some local anesthetic cream, and then wait for some time, and then separate it gently with a non-tooth forceps, and you can easily do it. If the child is very apprehensive, or child is younger, which is very difficult to do these things without causing local injury, then best is to take him to OT, give a short anesthetic, and gently separate it. One other thing you have to tell the parents is that please go on applying some sort of a cream locally, moisturizing cream or Vaseline or something, so that the raw area which are created by surgical separation do not adhere to each other again, and you don't get recurrence.
Correct. Can you get this Sainiki as an acquired and not just because of the non-separation of the labia? Like there was some injury, something, and then they are fused.
I suppose post-trauma can happen, but the post-trauma or there will be a sexual trauma. So that is something which is completely different ballgame altogether. Otherwise, there's no reason why it should be acquired. Even with gross infection in that area, you don't get labial fusion.
Okay, you can finish off the pylonary sinus part. What is the pylonary sinus? Which are to be investigated from imaging point of view, and which are the ones which can wait?
Yeah. So what you saw there was a very common lesion, which is at the tip of the coccyx, where you see a little dimple of the skin, and that is where the skin is adherent to the coccyx. And many times when you examine it carefully, you can see the floor of the sinus. If you're able to see the floor of the sinus, which is not having any hole there, you're pretty sure that this is just a simple pilonidal sinus, doesn't need any immediate treatment. If it becomes deep, if it has hair growth, or if it gets infection, then surgical excision would be required. Now, if you're not able to see the floor of the sinus, or if it seems that there is still a hole there, or there is a discharge that is coming out, then you need to do in a neonate and early infancy, you can even do a sonography and find out whether there is an internal communication or not. In an older child, you will need an MRI scan to investigate if there is a communication with the dural space.
Correct. So is it, I mean, I heard some neurosurgeons saying that it also depends on the distance between the anal verge and the pineal sinus. If it is within 1 inch and outside 1 inch, then it has a different connotation.
Yeah, I think he has probably spoken like a true neurosurgeon, because 1 inch for a newborn baby is going to be somewhere above the sacrum, and 1 inch for an older child is going to be very close to the anal. So I think we never
Oh,
go
this is
by
a newborn.
measurements.
While we
Yeah, we
examine the
never go by
newborn.
measurements. We go by the anatomical landmarks like sacrum, coccyx, and at any higher level than that, if there is a sinus, then it is a neuroectodermal sinus, something which you need to worry about.
Correct. So the worry is also that there could be a tract up to the spine and a tethered cord, which can lead to a problem later. So with an MRI, we'll pick that up.
Yes, MRI should be able to pick that up.
And then it is referred to the neurosurgeons to operate, or
if there is an intraspinal communication in today's day and age where we are practicing, I think it is safer to ask a neurosurgeon to intervene. But if you are a standalone pediatric surgeon where people are operating meningomyelocele, hydrocephalus every other day, then they are okay to go ahead with this procedure.
But if there is no tethered cord and just a dimple dip and there is an infection there, then that can be tackled by the pediatric surgeons?
Yes, that is local excision and just repair. Sometimes if it comes at an older age group, we have had patients who come at an older age group with recurrent infections, and then they develop multiple sinuses in that area. Then they need wide local excision and a flap reconstruction of that area.
And any hygienic precaution that you can teach to these parents when you diagnose them at birth that there is a pilometric sinus?
Basically to make sure that the child is given bath every day, and if there is a diaper, it needs to be changed, and don't leave the diaper for too long.
And for cleaning, while the stool should not touch that area or
no, nothing like that. Just wash it with water and soap. That's good enough.
All right. Okay, we move to the next. Dr. Ramesh, you can take the.
Normally, just a gross thing would be that sinuses which are located within the nasal cleft would be benign sinuses, and the chances of their communicating with the spinal canal would be quite less. I mean, just a rough guide. And the sinuses which are above the nasal cleft.
Correct.
Yeah, and those would be the ones which would be misbehaving.
All right.
Okay. Please continue. This is for you. So, what are the types of hemangiomas can be seen?
Well, I mean, hemangiomas they occur anywhere across the body. I mean, and they are grossly, I would normally divide them as superficial, deep, and mixed varieties, depending upon how they are. Superficial ones are normally located on the margin of the skin, and they are raised above the skin surface. The deeper ones are below the skin, and they give what is normally called just like a port wine stain or something of that sort. And the mixed variety would be where there would be both a superficial as well as a deep component.
So which one will respond to oral propranolol? Now our friends, they are using
the natural process for the superficial hemangiomas would be that they would have a growth phase for at least 8 to 12 months. And then after the period of 8 to 12 months, they normally start to show some degree of regression. And then most of them, they do spontaneously disappear by the age of 2 years, 1.5 to 2 years. They gradually start to resolve, and then they disappear. But nowadays, there is a lot of apprehension about hemangiomas, and parents always want something or the other to be done for their child. No sooner they see a hemangioma, and they come to us for early treatment. So in these cases, there is no harm in starting propranolol orally. Sometimes beta blockers locally can also be helpful, like timolol drops can also be helpful for treating hemangiomas.
So which dose propranolol oral?
I normally start them on 1 milligram per kg per day, and then I can gradually, reassess after every month, and we can gradually go up to maybe 3 to 4 milligram per kg per day, depending upon how the response is. If propranolol itself does not show the desired response, then you may also add oral or systemic injections of steroids.
Have you seen any complications from oral propranolol?
Now, I have not seen any complications of oral propranolol. As a routine, I do not advise a pre-medication echocardiogram for kids. I mean, and I've been doing this practice for almost 15 years now, not repented.
Well, and you said about
Because the amount
local.
of dose that you give is quite less.
So how long do you use? I mean, suppose there's a response, then parents want to know, can they continue? 3 months, 6 months?
Yes, sir, they can. I mean, if the propranolol is showing a good response, you can continue till about 6 to 9 months. There is no harm in doing that. And once the adequate response is achieved, it does not have to be a sudden stoppage. We have to gradually taper down the dose and then reduce it and stop it.
All right.
Now, when do you inject steroids? You said to be injected.
Sometimes when the hemangiomas are located over the important orifices, for example, they are around the eye, on the lip, near the nostrils, near the genital areas, and when they are slightly larger in size, or when they are subject to trauma, trivial trauma from any of the child's activities, propranolol gradually has a response. But when there is a hemangioma over the lip, seasonal injection of steroids does help to in slightly early resolution as compared to just oral propranolol.
So apart from steroids, any other things to inject?
Well, these are the two things that we normally use. I have used escarole in a few patients with a good response, but I normally try to keep that as a second or third line. But normally with steroids and propranolol, most of the children do respond.
So which steroid you triamcinolone?
Yes, I use triamcinolone.
And you repeat it or just once or?
No. If depending upon how the response is, I do repeat it after a month. Not before a month.
The maximum
after a month.
Maximum.
I've given about 5 or 6 sittings.
5 or 6. All right. And
yes,
there were some monoclonal antibodies available in the past. People used to use.
No, sir, no experience with using monoclonal antibodies. I mean, literature has shown that they have been used for vertebral hemangiomas where there is some disc compression or something of that sort. But personal, I don't have any experience, neither do I have any knowledge about using monoclonal antibodies. No.
Use of alcohol, hot water injections.
No, sir. No.
Ravi,
neither our training days. Ramadwar, sir, I mean, have you seen alcohol? Or
I have not injected, but yes, people have used STD, people have used hypertonic saline, people have used hot water, people have used alcohol. All kinds of things people have injected, but I don't think that is required.
Safest is steroid because it's time tested and something which you are used to, you should use it. It would
Even
really
oral
matter.
steroids can be given, so that's not
oral steroid. Yes, sure, right, all right.
So finally, which one will require operation, Amar?
Hemangiomas which are complicated, hemangiomas which are having ulcerations or recurrent bleeding, hemangiomas which have an associated lymphangiomatous component, for example, hemangiomas. These lesions are not going to disappear with just medical management. So in these lesions, there is a role for surgical excision. Sometimes parents do come to us that we do not want the child to be given medicines for 6 months, 8 months, 10 months, etc. And if the lesion is easily surgically resectable, then why not go ahead and resect it? But that would be a demand from the parents.
So one question, Dr. Amar and Dr. Ravi, both, that when you operate this, it's not very easy to find the plane because it might be much deeper than what you think. So in such case, what do you do? You can't leave it alone. I mean, you cannot just do half resection. It can bleed. Is there any role of arterial embolization for larger hemangiomas or some ones which are not accessible to surgical procedures?
Yeah,
for complex hemangiomas or AV malformations, yes, upfront embolization before surgery can be helpful. I mean, even for hemangiomas of the liver. Sometimes there may be extensive hemangiomas of the liver, and so if there is a good radiologist who can help us with selective embolization, that would definitely be a great help.
Correct.
Another situation where you need to operate.
Yes.
Another situation where you need to operate is if the hemangioma already contains phlebolytics, which can be felt as a firm or hard lesions inside the hemangioma itself. The rest of the hemangioma is compressible. That means there has been partial evolution of the hemangioma, but it's not going to resolve completely. And these are the hemangiomas will require excision.
Okay, fine, perfect.
So Nitin, I just finish it with the last.
Yeah. So the last question is, commonly parents are extremely worried. They see a white pearl-like swelling on the prepuce. What are the smegma pearls, Dr. Ravi, and how do you manage and how do you prevent?
Yeah, so basically smegma pulse are nothing but a part and normal process of physiological phimosis, where the foreskin is fused with the epithelial lining of the glands, and it
Correct.
gradually separates by collection of these dead epithelial cells, which give rise to pearl formation, and they will have intermittent discharge. They will come out when once the foreskin is separated from that particular area from the glands,
Correct.
and that is seen many times as an infection. It's actually not an infection. It's not a. It's just a cheesy material. No inflammatory signs are there, and you can see multiple of them in any child.
Correct.
It's not associated with phimosis. This is a simple process which is called as a fusion of the foreskin with the glands or adhesions
Correct.
between the foreskin and the glands, and that's a natural process of separation of foreskin from the glands. So don't do anything, just maintain patience.
So can you prevent it by some hygiene, or can you express them out, or there's no need to do anything?
Don't do anything because you can't prevent it. It's a natural process of separation
Correct.
of two linings, so you can't prevent it. And if
Okay.
you try to express it, it will cause more inflammatory response, some injury to the surrounding skin, and more scarring. So just leave
Okay.
it alone. Don't
I
get
think
excited that this is infected smegma.
right. So
The
I think
one request which I would like to make to all pediatricians on the group, whenever you see baby for the first time, you have growth charts, you have all kinds of charts, please mark also whether the child has got a hernia, hydrocele, and undescended testes and phimosis.
absolutely,
The
absolutely.
reason I am saying this is this becomes a very important document for us to go for insurance afterwards, saying
Correct.
that this was not present at birth, so you cannot call it congenital, because as you know from anatomical lessons, if anybody remembers from first MBBS, that at autopsy 35% of adults have a hernial sac which has never caused a hernia.
Correct.
So patent processes vaginalis itself doesn't give rise to herniation. There are certain factors which we are still unable to understand why herniation happens. So if you
Correct.
document on your neonatology assessment chart, discharge summary, or your clinic somewhere at least once, there is no hernia, hydrocele or something, then we have a solid proof to discuss with the insurance company that please kind of grant the insurance coverage for this condition.
Perfect. I think we discussed some 14 different types of common pediatric surgical issues that we see on an OPD basis. We have not touched upon the indoor patients like appendicitis, acute abdomen, injuries, etc. Maybe we'll do it some other time, because what is important for pediatrician is because these are the condition which a pediatrician is going to see first, and many times he may properly guide or misguide the parents. So I thought that's the reason why we wanted to have a collaboration with the pediatric surgeon. We really thank Dr. Robert, who of course had to go for his humanitarian work. We thank Dr. Amar Shah, our own Amar Shah from Gujarat, and my dear friend Dr. Ravindra Ramadwar for sparing your valuable 1.5 hours in a night on a working day, and giving real insights into these common 17 issues. And I'm sure the pediatricians who have attended will be enriched, because now they'll be able to take correct decision as to how to guide the parents before they can be sent to the pediatric surgeon for further therapy. So thank you everyone who have joined in late night for this yet another webinar. And again, to remind you that this webinar will be archived on the Gujarat Pediatricians YouTube channel. Maybe in next 1 or 2 days, we will get back to you on the groups with the links, so that those who have missed it, or you can pass it on to your friends so that they can see it. And if you want to see it again, you can see it at leisure whenever you want. They will remain on the YouTube channel forever. Thank you everyone, and good night. Dr. Ramesh, you want to say something?
Yeah. Thank you so much. And I'm very sure that today's session must have sensitized our pediatricians colleagues. And the most important thing is not only to suspect, to identify, but to refer as soon as possible, especially in case of acute scrotum and some other conditions. Thank you so much, all the eminent panelists, Dr. Amar Bhai, Dr. Ravindra sir, Dr. Robert, who had to leave, and my Gujarat Pediatrician WhatsApp group members, and all pediatricians colleagues across the country. Thank you so much. Good night.
Thank you. Good night.
Thank
Good
you.
night.
Thank you, Nitin
Thank
bhai.
you.
Thank you, Ramesh sir.
Good night. Good
It was a
night.
pleasure
Good
to attend with it. Thank you
Good
very
night.
much. Good night.
Good night.
Good night.